all the attendees for this new IMPERAS educational session. This is, I think, the 42 or 43 educational session. Today, we have a privilege to have here as a guest speaker Dr. David Papke from Boston. He is an assistant professor of pathology from Harvard Medical School, as well as associated pathology of Raymond Women's Hospital, Boston, USA. As you surely know, he is expert in soft tissue and gastrointestinal pathology, and that is really nice, David, that you have accepted to participate in this session. So you may share your seminar, your screen when you wish, and if anyone have any question, any remark, please write down in the chat box. I will be seeing the chat box, and I can advise to David that he has any question in the chat box. If anyone have to make directly a question to David by using the microphone, there is no problem, but please put first in the chat box, I would like to ask a question, then I told that you may ask the question, because to make some kind of order, it's, you know that there is so many people joining, and this will be better by using the chat box. So David, thank you, and you can start when you wish.
Sure. Well, thank you, Isidro, very much for the invitation to speak here. I really appreciate that. And, you know, as I was telling you, I understand that this is an audience of people who are very interested in sarcomas and who already know quite a bit about sarcomas. So today I'll try to emphasize new and emerging entities. But then as we go, I'll also hit on a few practical points here and there too. So, and as Isidro said, I'm a pathologist here at Brigham and Women's Hospital and Harvard Medical School in Boston, and I sign out bone and soft tissue pathology and also gastrointestinal pathology. So I might throw in a few GI mesenchymal tumors as we go here. Okay, so I will share my screen, and this is an informal session, so please do feel free to ask questions throughout the session. All right, well, I'll start with a case that I recently signed out. This is a pleural mass in a 63-year-old woman. So you can see here that this tumor is at low power, sort of marbled. It has some alternating areas that are hypercellular and hypocellular. It's a myxoid spindle cell neoplasm. There's some perivascular condensation of tumor cells. This really looks like it ought to be a malignant peripheral nerve sheath tumor in the pleura of an older patient. The clinical would fit very well with that diagnosis. And the whole tumor basically looks like this. There are several blocks that all look the same. So, I ran my MPNST markers in the first round. Here is H3K27ME3. This is an antibody, of course, that recognizes this trimethylated lysine residue on histone H3, which is demethylated in about 80% of high-grade MPNSTs, so where you would see loss of expression. You can see that this tumor fortunately had retained expression, which certainly can happen in high-grade MPNSTs, but is usually expression is lost in a high-grade tumor like this. But the stain that surprised me was SOX10. So you can see SOX10 is mostly negative, and of course, high-grade MPNSTs are usually negative for SOX10. This is expected, but here's the unexpected finding. In one small focus of this tumor, there are these nests that are SOX10 positive. And of course, these nests don't belong in the pleura. This is part of the neoplasm. And these nests are also positive for S100, which is negative in the rest of the tumor as well. So that prompted me to go back and look a little more carefully at the morphology. And you'll notice that actually in just this one spot, there are these nests of epithelioid cells, and in higher power you can see some of them even have prominent nucleoli. And of course you wouldn't expect to see these nests in an MPNST. I'll show you a couple more stains. Here's MART1. So there's some hemosiderin, but then you can see that there's a dark brown staining in some of the tumor cells. So they even have MART1 expression. And the most impressive stain in this case, this is BRAF V600E. So this is a mutation-specific antibody for the BRAF V600E mutation. You can see it's diffusely positive in the tumor. So this, of course, as you all know, is a metastatic melanoma, which is 99% dedifferentiated and unrecognizable. And I got very lucky that there was a small focus of recognizable melanoma that stained with SOX10 and S100. So it turns out, I learned after the fact, I looked into the history more deeply, and this patient had a history of a cutaneous melanoma about 2 years prior. So she even had a history of melanoma. And I'm just showing this case as a practical point before we enter into all these esoteric, new emerging tumor types, that you have to be careful, take into account clinical context. If it's a pleural mass in an old patient, or if it's an older patient with multiple liver masses or widespread metastatic disease, melanoma and sarcomatoid carcinoma are always in the differential diagnosis. And, especially in older patients with metastatic disease, you have to rule out that possibility. Also, having a history of melanoma should make you suspicious that the tumor you're looking at that looks like a sarcoma might actually be a melanoma. Dedifferentiated melanomas are a big problem diagnostically. There are a couple of very nice series by Abasa Gamey that came out a few years ago talking about how to approach these tumors. Sometimes you get lucky, like in this case, and have a differentiated component, or sometimes these can stain positive for mutation-specific antibodies for BRAF V600E or NRAS Q61R. So we use those stains in our practice to support the diagnosis of metastatic dedifferentiated melanoma. But unfortunately, dedifferentiated melanomas are enriched for other mutations. So oftentimes you end up just relying on the history, or if you think it might be a dedifferentiated melanoma, but you're not getting any stains to support it, you may actually have to go to molecular testing to look for a UV signature to support the diagnosis. But anyway, this was just to put in a little practical reminder before we enter all of these esoteric tumor types that we're going to be discussing. Do you have any questions about dedifferentiated melanoma, approach to melanoma?
Do you use a PRAME stain for this?
Oh, frame. Yes, I'll show you a frame. So here's PRAME in this case. I did run it, and it is positive including in the myxoid spindle cell component. So I think PRAME is very useful in certain contexts. I think it's very useful if you have a cutaneous tumor and your differential diagnosis is melanoma versus AFX or pleomorphic dermal sarcoma, versus carcinoma. I think PRAME is very useful in that context. I think when you're dealing with a tumor in a soft tissue site, you have to be very careful because PRAME can stain some mesenchymal tumor types. And as you know, there are a bunch of papers about this now in the literature about how when your differential is melanoma versus sarcoma, it's actually not the most specific marker. Still pretty sensitive, but not so specific. Okay. Well, so now we'll move into some mesenchymal tumor types. So here's the first one. This is an emerging tumor type. So this patient...
Sorry, David. The concept between dedifferentiated melanoma and undifferentiated melanoma, you have to see. Because usually in soft tissue tumor, to make this diagnosis, so to dedifferentiated tumor, you usually saw well differentiated area that the melanoma. I don't know what is a well differentiated area, but what is exactly the difference between the dedifferentiated concept, transdifferentiation, and undifferentiated component in melanoma? Because it's really tricky.
Yeah, the terminology could be a little confusing potentially. But yeah, that's exactly right. So this case, because it had a nice differentiated component, we knew the rest of it was dedifferentiated. If you don't have the
Okay.
differentiated component, then we use the term undifferentiated melanoma. Um, but these different, these different terms, these are differences. But I think from a clinical management standpoint, if you're calling it melanoma, they'll sort of know what to do. So I think we want to be accurate, of course, but we probably don't get too hung up on those distinctions here, I would say. But certainly, if you have a differentiated component and then an undiff component, then it's appropriate to call it dedifferentiated. Yes.
Okay.
Cool. Okay. Well, so here's the next case. So this patient is a 78-year-old female, and she presented with multiple abdominal tumors. She underwent a debulking, and then they recurred a couple years later. So this is a biopsy of the recurrent abdominal tumors. So I'll drive just at low power through the core. You can see kind of at low power, it all looks pretty similar. So this is an epithelioid neoplasm. It looks fairly monomorphic. The neoplastic cells have these large vesicular nuclei. Some of them have eccentric eosinophilic cytoplasm. So this morphology we call rhabdoid. Let me find a better focus. So this cell here would be a good example of a rhabdoid cell with an eccentric nucleus and eosinophilic cytoplasm. So when you see this morphology, and the whole tumor basically looks the same in this case. It's just these sheets of epithelioid and rhabdoid cells with vesicular nuclei and these distinct nucleoli. So when we see this morphology, my mind goes straight to SMARCA4 deficient carcinoma, INA1 deficient carcinoma. But in this particular case, SMARCA4 and INA1 expression was retained. And so then we see these cases that look like this actually pretty frequently. We actually have a general term we use, undifferentiated epithelioid malignant neoplasm, where you see these tumors, and often we can't classify them. But in this particular case, this is something specific. And one feature here I'm just going to point out before we talk about stains is you will notice there are these collagen deposits around. And this is actually a common feature in this tumor type. I'll show you a few examples. But so sheets of rhabdoid cells and some stromal collagen in areas. So this tumor is negative for almost everything. It's negative for keratins. I'll show you CAM 5.2. So keratins are negative. You could wonder if it's a rhabdomyosarcoma maybe because it has rhabdoid cytomorphology, but Desmond is negative. This is Desmond. Of course, most tumors with so-called rhabdoid cytomorphology are not actually rhabdomyosarcomas, but occasionally they are. And really, there's one stain that's important. And I'll just spoil the fun and tell you what it is. Sorry. So there's one stain that's positive. And this is NUT. So this is a, and yes, sclerosing epithelioid fibrosarcoma. I saw that pop up in the chat. That's actually a reasonable consideration because of the collagenous stroma, and those can metastasize to the peritoneum or even rarely occur primarily sort of in the abdomen. So that's definitely a reasonable consideration. But this tumor, it turns out, has a NUT gene rearrangement. So you could wonder if this is a NUT carcinoma. And in fact, we had seen the primary tumor in the era where there only were NUT carcinomas. So that's actually what we had called it several years ago. But it's a little bit weird for a NUT carcinoma. It's negative for keratins. It's negative for CK5, which I'm showing you here. It's negative for P40, which I'm showing you here. So NUT carcinomas, of course, are translocation-driven squamous cell carcinomas that generally show expression of P40 and CK5 and keratins, which this was negative for. So it turns out that the fusion partner in this case is not BRD4. The fusion partner instead is MXD1 in this case. So this is an MXD1 NUT M1 fusion. And so this is an example of this emerging class of sarcomas, which right now we're just calling NUT rearranged sarcomas. Let me just show you the morphology of the tumor one more time, and I'll show a couple more examples. So these NUT rearranged sarcomas are actually look to me quite similar to SMARCA4 and INA1 deficient tumors. They have big vesicular nuclei that are relatively monomorphic. They have prominent rhabdoid cytomorphology. Some examples are more spindled. I'm going to show you another example now of a NUT rearranged sarcoma. This one, actually, this is a nice sample because you can see how infiltrative the tumor is. These are extremely infiltrative tumors. They have a predilection for the abdominal cavity, and if you get an omental biopsy, you'll see they just diffusely infiltrate the omentum like we're seeing here. And when these are spindled, like we see here, they remind me a little bit of synovial sarcoma. Not quite, but they're very monomorphic. They have overlapping nuclei. But again, they have these vesicular nuclei and prominent nucleoli, which would be a little bit weird for a synovial sarcoma. So this tumor that I'm showing you now is actually quite interesting. So we have a series of these, which we're revising right now. It's been accepted pending revision, so it should be out hopefully pretty soon. This tumor has an interesting fusion. So this tumor is positive for desmin. 40% of these NUT rearranged sarcomas express desmin. 40% also express keratins, but they do not express squamous markers. They're negative for P40, negative for CK5. But interestingly, this case I'm showing you is negative for NUT. And that's because this tumor has a gene fusion between MXD4 and NUT M2G, not NUT M1. So there are tumors that fit within this emerging class of NUT rearranged sarcomas that have alternate NUT gene fusions with NUT M2A and NUT M2G. That hasn't been reported yet, so that's sort of part of the series. I'm actually going to show you one more tumor, and then I'll show you a figure sort of summarizing some findings in these NUT sarcomas. But so keep those two cases in mind that I just showed you, because this case, which is another NUT rearranged sarcoma, looks quite different. And if you read about these in the literature, you'll read that there's morphologic heterogeneity. And I think we know the reason now. So this tumor occurred in the orbit of a 1-year-old child. So it's unfortunately a very bad location that this kid ended up having to have an enucleation. But anyway, this tumor looks quite different from the two tumors that I just showed you. And when I got this, my first thought was it looked like an NTRK rearranged tumor. It has prominent stromal collagen. It has spindle cell cytomorphology. It does have some mitotic activity. If we look around, we can find mitoses pretty easily. But it looks atypical. You'd be worried that it's a sarcoma, but this doesn't look so overtly malignant as the two other cases I showed you. And it has very different cytomorphology. So this tumor also has a NUT fusion. Here's the NUT stain. So this one has a NUT M1 fusion. So we can use our NUT M1 IHC, which is nicely positive. But this tumor also showed some expression of CD34 and even a little bit of S100. It's not a ton, probably mostly histiocytes, but I think some of the spindle cells are positive. So really, this tumor, it would have been easy to think this was probably an NTRK rearranged tumor with some S100, some CD34, spindle cell morphology, collagenous stroma. But sequencing showed that this had a fusion between NUT M1 and MGA. So I'm gonna share a figure with you right now, so you'll see kind of what I'm getting on about here. Oops, I stopped my share. Sorry. So this is from this series, which hopefully should be out relatively soon. So if you read about these NUT sarcomas in the literature, you'll see that there are these different fusion partners. And they all fall within the same gene class. So there's MGA, MXD1, MXD4, MXI1. And these genes are all so-called max dimerization proteins. So these normally dimerize with another transcription factor, MAX, and that inhibits MYC activity. But when these fuse with the NUT genes, they become oncogenes, and they actually mimic MYC. They act like MYC, and they drive a MYC transcriptional program, which has been shown previously, and we found in our study as well. So these sort of act like a MYC gene, and then as you'd expect, because MYC is sort of a bad oncogene, these are bad acting tumors. But what's interesting, so we noticed in our series, and then what I'm showing here is actually a comprehensive literature review plus the cases in our series. So here's an age distribution. The tumors that have the MGA fusions are shown in purple, and the ones that have other gene fusions are shown in green. And you can see that the MGA rearranged tumors have this bimodal distribution. Some of them occur in pediatric patients, and then some of them occur in older adults. Whereas the tumors that have the other fusion partners, MXD1, MXD4, and MXI1, occur in older adults. We found some clinical differences as well in terms of behavior. So the tumors that have MXD1, MXD4, and MXI1 fusions are very, very aggressive. Over 90% in the literature and in our series metastasize. The median survival is about 1 year. These don't respond to chemotherapy. These patients just do very poorly. The MGA tumors, they're still sarcomas, they metastasize, but the ones in pediatric patients only have about a 33% metastatic rate, so it's a lot lower. And when they do metastasize, these tumors tend to have a more protracted course. The patients develop metastases, but it's over a longer time period, and they're not as aggressive. So of course, these are still sarcomas, and they still can kill patients, but they're significantly less aggressive, and they look somewhat different. So as I showed you in those cases I just showed. So we think that these tumors that have MGA NUT fusions are probably different than the ones that have other MAD sort of gene family member fusions. There are also some quite interesting clinical differences. So the MGA fusion tumors are shown here with the crosshatches, and the other tumors are shown with these different patterns. So you can see there are no crosshatches in the abdomen. The MGA tumors have this predilection for the lung, and then they occur in somatic soft tissue sites with a pretty wide body site distribution. But they really don't seem to occur in the abdomen, or at least if they do, it's pretty uncommon. Whereas the other tumors almost exclusively occur in the abdomen, either in the abdominal cavity or in abdominal organs. And there's also this interesting difference in sex distribution. So these other tumors have a striking predominance in females. They almost all occur in females, something like 80% or 90%. Whereas the MGA rearranged tumors have a more even distribution between males and females. So, this is an area that I think is still emerging, and there's still a lot more work to be done. But I think when you read that these tumors have inconsistent morphology, the reason you're reading that is because the MGA tumors look different from the other ones. I think the other ones actually all look pretty consistent with one another. And the MGA tumors have a pretty consistent morphology as well. I think the trouble is right now they're all sort of being lumped together, and then that makes it look like a heterogeneous tumor type. But anyway, so this is something I think to come, and it's not just our group. I know there are other groups that are working on these tumors as well, and I think we'll get a handle on them hopefully pretty soon as a field. Do you have any questions about NUT rearranged sarcomas?
It's usually lymph node metastasis.
Lymph node metastases? No, these tend to, so in our experience, the peritoneal tumors often, they do go to the lung. They often metastasize around the abdominal cavity, but not clearly in lymph nodes, usually more to sort of visceral sites like the lung or the liver. And they also, interestingly, they don't arise from, as far as we can tell, they don't seem to arise from epithelium. The NUT carcinomas, often you'll see them coming off, epithelium in the head and neck or wherever they're originating. Not always, but oftentimes you do. Whereas these don't seem to originate from the epithelium, even when they occur in like the colon, organs that have an epithelial component to them. These usually tend to occur in the wall of the colon or in the uterus or other organs that are in the abdominal cavity. I think the real thing that we need to figure out is, I think we're still missing a lot of these. So we can recognize these tumors now because they have this very characteristic morphology with rhabdoid cytomorphology, vesicular nuclei. But I think the trouble is right now we just have IHC for NUT-M1. And I think we're missing the tumors that have NUT-M2A and NUT-M2G fusions. And we happen to just find those through a sequencing database. Otherwise, we would have never found them. So I think there's an unmet need there to have a way to diagnose these tumors that have alternate NUT gene fusions. They're actually not covered in most targeted panels either. So really, right now I think it's an area where we have a blind spot.
Okay. Any question for the audience? Any comments, remarks?
Yeah, I'm Dr. Jian Wang from Shanghai. We
Hello.
also have experience with about 10 cases.
Yes.
And recently we have encountered a case which occurred in the abdominal and showing metastasis to lymph nodes.
Okay.
One case, yeah. Very interesting case. Thank you very much.
And you have a nice series on them already. I'm quite familiar with your series.
Right. Okay. Thank you.
Yeah, of course.
Thank you, Professor Wang. So there is two questions in the chat. Is the NUT immunohistochemistry almost 100% specific for this as for the traditional NUT midline carcinoma?
Yeah, so NUT immunohistochemistry is very, very specific for the NUT-M1 fusions in general. So in the carcinomas and in the sarcomas, it's a very specific marker. So yeah, it's a really useful stain. The trouble is that it doesn't help if it has a different NUT gene fusion, like NUT-M2A or NUT-M2G. So the NUT-M2 fusions are not covered by NUT-M1 IHC. It only picks up the NUT-M1 rearranged tumors, which is still most of them as far as we know, but I think we're missing a subset. I'll mention we've also seen a couple NUT carcinomas now, and this is another, I think this paper has been accepted and will be published soon. A couple NUT carcinomas that have NUT-M2 gene fusions as well. So it seems like most of these tumors probably have NUT-M1 fusions, but there's a small subset that have fusions involving NUT-M2 genes. So yeah, something hopefully to come soon.
And maybe before the era of not antibody and not fusion, may we have missed this case, of course, because if we don't have the not antibody or the molecular techniques, how do you think we have diagnosed this case in the past before the NUT era?
Yeah, so I think it is very hard if you don't have access to testing for NUT in some way. We're lucky that we have the antibody here, which makes it easy for us. If we're thinking about it, we can just run the stain. But I would say if you see, so there's certain features that can make you think about these tumors. If you see the vesicular nuclei, very uniform looking, and also these tumors, they're very infiltrative, and they often show, if I can find it, this prominent stromal collagen. That's a feature that's sort of unusual in other tumors that can look rhabdoid. Like you don't see prominent stromal collagen in SMARCA4 deficient tumors or INA1 deficient tumors so often. So this is a feature that could really make you think specifically about NUT rearranged sarcomas. And then if you think about it, if you don't have access to the IHC in your institution, it's certainly available. I know in the United States as a send out test, and I'm guessing in a lot of other countries there's a way to perform the stain. Or alternatively, you could run FISH for NUT-M1 to look for gene rearrangement. But I think if you see this morphology and the tumor is INA1 proficient and SMARCA4 proficient, that's when we start thinking about NUT deficient tumors. yeah, these are definitely a diagnostic challenge. But I think it's
Yeah.
partly, again, because the literature has been a little bit mixed up on these tumors. And I think if we take out the MGA tumors, the rest of them actually look quite consistent and look like these undifferentiated neoplasms.
Yeah. Any further question, please? So you don't think that in this case, will be the same with the smart CI4 that start to be sarcoma, continue to be carcinoma, and finally to be undifferentiated tumor? What do you think about this?
Well, this is a very interesting question. You know, these tumors, I would argue that these nut rearranged tumors that I'm showing here are sarcomas. They don't arise from epithelia. So you know, the nut carcinomas arise from epithelial sites generally, whereas these nut rearranged sarcomas do not. They often express desmin, which is very uncommon in carcinomas, especially to see diffuse desmin expression. Um, it is sort of a philosophical question. You know, there's no, as far as we know, there's no normal tissue counterpart, but there are all kinds of sarcomas that don't have a normal tissue counterpart, like synovial sarcoma. You know, we don't know what that has no normal tissue counterpart, just as an example, um, and doesn't have a clear, you know, line of differentiation other than some epithelial differentiation. So I would argue conceptually, since these are arising from soft tissue sites, and because they're not really showing evidence by immunohistochemistry of epithelial differentiation, I would argue that these are sarcomas. I think that, you know, it is a philosophical question whether we should reclass it. You know, all these sarcomas that don't have a, you know, normal mesenchymal counterpart. It's sort of a philosophical question about whether we should be calling them undifferentiated neoplasms instead. I'm afraid that would be a little bit confusing for clinicians. You know, I think if you tell a clinician that this is a sarcoma, they sort of understand what that means. They know this arises at soft tissue, and then you can tell them it's aggressive and whatever. If you tell them it's an undifferentiated neoplasm, I think they may be sort of confused, and they don't know if you mean that it used to be a carcinoma and it's gone bad, or if it, you know, so for that reason, I would tend to prefer sarcoma terminology. But I think if you ask different people that same question, you'll probably get different answers, and that's sort of a philosophical question in a way.
Okay, thank you. Any additional comments or remarks?
So for these tumors, I see in the comment the question about grading and staging. You know, fortunately, some of these, so this tumor type I just showed you, these not rearranged sarcomas. I mean, it's actually very unfortunate. They're so high grade and so aggressive that the ones that have the fusions with MXD1, MXD4, and MXI1, I think those should be definitionally high grade sarcomas. The MGA sarcomas, I think your question is quite interesting. The one I showed you in the orbit actually didn't look that high grade. And that one, we have, I think, a year of follow-up on it, and it hasn't recurred in a year, whereas these other ones tend to recur rapidly and, you know, be more aggressive. So there may be some role for grading in the MGA nut sarcomas. When I signed it out, I did grade it. I said low to intermediate grade based on the sort of morphologic features. But I think it sort of remains to be seen if grade is meaningful in these, or if, you know, for a lot of these soft tissue sarcoma types, even when they look low grade, they could sort of still be pretty aggressive. So I think we just don't have enough data right now to know. Okay.
Okay.
Good. I'm glad that you guys are asking questions and you're interested in these tumors. That's fun. Okay. So the next tumor type I'll talk about is one that I sort of always feel compelled to talk about because it's sort of the most distinctive tumor type I think I'll ever have the opportunity to work on. So this is a occipital mass. So it was in the occiput, sort of near the spinal column, in an 81-year-old male. Slide. So this tumor, oops, I'm sorry. So at low power, you can see it's growing mostly in sort of a sheet-like fashion. Maybe these, you could argue there's some very large lobules of tumor. And as I mentioned, this is near the spinal column, and this tumor is actually infiltrating around this vertebral bone here. You know, it's actually, even though this tumor sort of looks lobulated, it's also quite infiltrative at the same time, which is typical of this tumor type. It's lobular and infiltrative and locally destructive. So this tumor has this quite curious look. There are these trabeculi and nests of tumor cells. Oh boy, I see people are already putting the answer in the chat, which is fine. Yes, that's the answer. It's pseudoendocrine sarcoma. Anyway, this tumor has trabecular architecture and nested architecture, and it really looks like it should be a well-differentiated neuroendocrine tumor. These neoplastic cells even have salt and pepper chromatin, you know, speckled chromatin like we see in well-differentiated neuroendocrine tumors. It looks very monomorphic. This is probably one of the most monomorphic tumor types that you'll ever see. Every cell looks pretty much the same. But the interesting thing about this is if you stain it, so it looks like a well-differentiated neuroendocrine tumor, but it doesn't stain right. It's negative for keratins. Here's pan-keratin, which is dead negative. So of course, well-differentiated neuroendocrine tumors are always positive for keratins. They're essentially always positive for keratins. So a negative keratin really rules out that diagnosis of a well-differentiated neuroendocrine tumor. Neuroendocrine carcinomas can lose expression of keratin, but this doesn't really look like a neuroendocrine carcinoma. This looks like a well-differentiated neuroendocrine tumor. So that should definitely give you pause. And this tumor is negative for neuroendocrine markers. Here's synaptophysin. Chromogranin is also negative. And this tumor was only positive for one marker, which is shown here. And this, of course, is beta-catenin, which is showing nice nuclear staining. So this is a pseudoendocrine sarcoma, as everybody was guessing correctly in the chat. So this is a tumor type, actually, that Dr. Fletcher had recognized all the way back in the late 1990s. And he just started collecting cases from the late 1990s of these tumors that looked like neuroendocrine tumors but didn't stain right. And then I did a fellowship with him. It's been now, I think, four or 5 years ago. And when I started the fellowship, you know, we were thinking about projects, and he said, "Why don't you just look at these neuroendocrine tumors and see what you can find in them?" And it turned out actually that there were two different tumor types in that set of things. And one of them is this. So one of them is pseudoendocrine sarcoma. So these tumors, these pseudoendocrine sarcomas, have a striking predilection for paravertebral soft tissue. About 80% of cases, or maybe even more, occur next to the spinal column. Rarely these can occur in other sites. So we've seen one in the thigh. I'm aware of an unpublished case that also occurred in the thigh. So these can occur sometimes in other soft tissue sites, but they almost always occur in paraspinal soft tissue. And they really just all look the same. These tumors have trabecular and nested architecture, very monomorphic nuclei, and yeah, they look like well-differentiated neuroendocrine tumors. These are locally destructive. So as you see in this case, it was effacing the vertebral bone. These tumors have a pretty significant local recurrence risk. It's about 40%. And when these recur locally, these can be very destructive. They can impinge on nerves and cause problems for the vertebral bones. And these also, even though they look very bland and are usually pretty low on mitotic activity, these metastasize. 20% of these metastasize, usually to the lung. I'm aware of an unpublished tumor that went to the liver as well. So these seem to have hematogenous spread to distant organs. And I'll just show you two other cases to kind of show some other morphologic features. This is another one. This tumor occurred in, this is also in paravertebral soft tissue in a 71-year-old male. Oh, I should have mentioned these tend to occur in older adults. I think the youngest patient we saw was in their 30s, and the median age is about 65. They can even occur in elderly adults. This case I pulled because it has another feature that's sort of distinctive in these tumors. So this one has these extracellular hyaline globules. And we saw these in over half of the cases in the series. And in the case reports that have come out since our original series, this has been a pretty consistent feature. So this is actually a helpful clue when it's present. They even kind of, once you know they're there, they even sort of stand out at low power, all these hyaline hyaline globules. This one has a little bit higher of an NC ratio. Your differential diagnosis on this one might be a little bit different. You could think about a round cell neoplasm maybe. But again, that speckled chromatin and trabecular growth would still make you think probably about a well-differentiated neuroendocrine tumor. And then one other feature that is seen in about a third of cases is this. So this example here has these beautiful pseudomonas calcifications, which again, that's a feature present in some well-differentiated neuroendocrine tumors and might make you think about that diagnosis. But yeah, so pseudoendocrine sarcomas have mutations in the beta-catenin gene. They all occur in this ubiquitination motif of the gene. So they're different mutations than you see in desmoids. You know, desmoids have these phosphorylation site mutations in most cases. That's really the only consistent genetic abnormality we've seen. We didn't see any recurrent copy number alterations or no other recurrent second hit mutations. It seems like beta-catenin mutations are sufficient to drive this sarcoma type. And yeah, it's just a very unique sort of looking tumor type. So I wanted to show you an example. If you see one, if you see a tumor in perivertebral soft tissue that looks like a well-differentiated neuroendocrine tumor, but doesn't stain right, you should think about this. And yeah, I see in the chat this question about solid pseudopapillary neoplasms. And that was something we thought about pretty thoroughly and carefully when we published the original paper, because we had the same question. These have some overlap. They have the same mutation. So solid pseudopapillary neoplasms have those same ubiquitination motif mutations. So genetically, you know, they're sort of similar. And there's some similarity in morphology. Solid pseudopapillary neoplasms can also look sort of endocrine. You know, in the pancreas, they present a pitfall for misdiagnosing a neuroendocrine tumor. We think there's some morphologic differences. So the cytomorphology is different in these tumors. Solid pseudopapillary neoplasms usually have more folded nuclei. They're a little more irregular, whereas these have these round nuclei with speckled chromatin and more nested architecture. These pseudoendocrine sarcomas generally don't have pseudopapillary architecture, so the architecture is also a bit different. And as you know, solid pseudopapillary neoplasms often express synaptophysin. That's actually a major pitfall in the pancreas, whereas these pseudoendocrine sarcomas never expressed neuroendocrine markers. We stained all of them. So there's some differences, also clinical differences. So solid pseudopapillary neoplasms have a predilection for females, and they occur in younger patients on average, whereas pseudoendocrine sarcomas actually have a slight male predilection, and they tend to occur in older adults. So the demographics are different. So we felt there were enough differences where it didn't make sense to lump them. But I do suspect that they may be sort of biologically related. You wonder if maybe they're trying to show a similar line of differentiation or something like that. But yeah, so it's an interesting question. I do think that they're probably or potentially are related tumor types, but I think there are enough sort of clinical differences and morphologic differences to justify separating them from a classification standpoint.
Yes, this is the same situation with pancreatoblastoma when we are dealing with a tracot biopsy, and we we cannot see the squamous cell in its supposedly peritoneal tumors, and we make a beta-catenin, and this is positive. We can call this a pseudoendocrine sarcoma if we don't see pancreatic mass. So that is some quite similar situation.
And it's actually even more complicated. You know, these beta-catenin mutant tumors, actually there are other ones that look similar too. Microcystic stromal tumors of the ovary actually look very similar to these tumors as well. And I think historically some of those were diagnosed as solid pseudopapillary neoplasms of the ovary. So I don't know. I think these tumor types may all be sort of related to one another. But because there are clinical differences, and especially I think because there are outcome differences, these pseudoendocrine sarcomas are more aggressive than solid pseudopapillary neoplasms. I think it may be actually more confusing to clinicians if we lump them because the outcomes are different, you know. But yeah, I think from a sort of biologic standpoint, I do wonder if they're related. Okay, so that's that case. I had to share some pseudoendocrine sarcomas, of course. And now, we'll move on to another tumor type. I'm going to introduce this by talking about a couple established tumor types, and then we'll get to the more novel one at the end. And I'm guessing this may be kind of where we end up with the session today. So this tumor is a gastric mass in a 34-year-old male. And this is not meant to be a trick. So this tumor at low power, even at low power, you can tell it's quite inflamed. There's the muscularis propria of the stomach. Sorry, it's a little bit faded looking, but you can see that the tumor is abutting the muscle and probably infiltrating the muscle a little bit. So this tumor is very inflamed. It is a vesicular spindle cell neoplasm. And as we go on higher power, the whole tumor sort of looks the same. So it all sort of looks like this, where there are these fascicles of neoplastic cells that have vesicular nuclei, small distinct nucleoli. There's cytoplasmic tails. You know, this looks myofibroblastic on morphologic grounds. And of course, then this is an inflammatory myofibroblastic tumor of the stomach. And I will show you an ELK stain, which you can see is very nicely positive and also highlights that vesicular architecture. So I'm showing you this first just to emphasize that inflammatory myofibroblastic tumors generally have vesicular architecture, and they look, you get these spindly myofibroblasts within the fascicles that kind of look the same from case to case. These have a pretty uniform look to them. So as you know, just over half of inflammatory myofibroblastic tumors have ALK gene rearrangements, especially in younger patients. They tend to have ALK rearrangements. As patients get older, they tend not to have ALK rearrangements as often. And this is a tumor type that's sort of thought to have intermediate biologic potential, where a small subset, probably less than 5%, metastasize distantly. The ones that metastasize distantly usually occur in the abdomen or the lung. So IMTs of somatic soft tissue generally don't metastasize. And I actually wonder a little bit if we were to go back and look retrospectively at some of those series. I think some of the ones that were reported to have metastasized might have actually been epithelioid inflammatory myofibroblastic sarcomas or other tumor types, because the ones that metastasize tend not to have ALK rearrangements. And our diagnostic criteria have changed so much since those original series have come out. So I actually suspect a little bit that the metastatic risk is even lower than what's been reported in the literature, just because we so rarely see metastasizing conventional IMTs. But anyway, so that was just to set the stage. So that's what IMTs look like. They're vesicular and inflamed. So here's another tumor type that's sort of well described, a related tumor type. So this is another abdominal tumor, this time in a 12-year-old male. This tumor is in a lymph node. Sorry, the slide is dirty. And so this tumor has some morphologic similarities, but also some differences. So this tumor is inflamed, but it's much more epithelioid than the last case that I showed. These cells actually look somewhat similar to the ganglion-like cells you see in proliferative fasciitis. They have these big vesicular nuclei, prominent nucleoli, amphiphilic cytoplasm. And in areas, I think this tumor even has some neutrophilic infiltration. Let's see. I'm not finding that feature super easily here. Most of these tumors have prominent neutrophils. This one, they're a little less prominent. Anyway, this tumor also expresses SMA. It looks myofibroblastic, just like the IMT I had shown. And this tumor expresses ALK. But you'll see that the ALK expression pattern is a little bit different than what we just saw. This tumor has this very distinctive ALK expression pattern. It's actually expressed in the nuclear membranes. So this nuclear membranous ALK expression is characteristic of this tumor type, So this is an epithelioid inflammatory myofibroblastic sarcoma. These tumors have ALK rearrangements just like IMTs, but the fusion partner is usually this gene RAN-BP2. It's a nuclear binding protein, and that causes the fusion oncogene to localize to the nuclear membrane. So you get this characteristic nuclear membranous staining in most cases that correlates with that fusion. So these epithelioid inflammatory myofibroblastic sarcomas are very aggressive. They tend to occur in the abdominal cavity. They have a slight male predominance, actually a pretty significant male predominance. And these are very aggressive tumors, although we know now that they respond to targeted ALK inhibitor therapy. I think there aren't many data on long-term outcomes and how long they respond for, but at least initially, they're usually pretty chemo-responsive. I see a question in the chat.
Yes, there is no question. Yeah.
Yeah, usually in IMTs, it's sort of all or nothing. You know, you'll see lots of ALK expression or no ALK expression correlating with the gene fusions. That's sort of my experience. We do occasionally see cases where we see diffuse weak expression, and those are cases where then we go to FISH for ALK to prove the fusion or to see if it's there. But normally we can, you know, like in a case like this where you have such a perfect staining pattern, there's no doubt that this has one of these RNBP2 ALK fusions. So in a case like this, we wouldn't need to go to any kind of molecular testing. Okay, so I showed those two tumors to set the stage for the tumor type that I wanted to talk about. I guess it'll probably be last. So I'm going to show you some tumors. This is a tumor type that we published on just this past summer. So this is an abdominal mass in a 22-year-old female. She actually presented with multiple abdominal masses. And so at low power, this tumor, you can appreciate, is very myxoid. And this tumor is very infiltrative as well. So this is omental adipose tissue. And this tumor is just infiltrating through the omentum, you know, really in a really striking way, in a way that's unusual for IMT. You know, inflammatory myofibroblastic tumors can have somewhat infiltrative peripheries, but they're not usually infiltrative to this degree where they're really just, you know, infiltrating all kinds of native tissue. And this tumor is quite multilobulated. So you can appreciate that there are these sort of individual lobules of tumor cells that are infiltrating through the adipose tissue, which again is unusual for conventional IMTs. They're not usually multilobulated neoplasms. Usually they grow as one big mass. I'll show you another block of the same tumor. Again, you can see it's just happily infiltrating through the omental fat in a way that is unusual for IMT. So if we look at the cytomorphology, this tumor looks, again, myofibroblastic. It has these cells that are spindled. If I drive around, I think we'll be able to find some stellate cells. Go over here. Some more stellate cells, some spindled cells. Again, there are these vesicular nuclei, small distinct nucleoli. And this tumor really doesn't have any significant nuclear atypia. It looks quite bland. It's worrisome that it's presenting with multiple abdominal masses and that it's so infiltrative. But on morphologic grounds, it would be hard to call this malignant. It really looks like it could potentially be a benign tumor. So, you know, we got this case. This is when Dr. Fletcher was still here. This came to a service. I was sitting in on sign out. You know, we looked at it. And the question was, is this an IMT? He felt it was different, wasn't sure what it was, signed it out descriptively. And then a few weeks later, this case came in. This is a recurrent abdominal tumor. Different patient. This patient is in her 30s, I believe, 36. And it's the same thing. It's a myxoid, infiltrative, lobulated tumor that looks myofibroblastic. This was another young female patient with multiple abdominal masses. Again, this tumor is extremely bland, but you know, this is a recurrence. She had multiple tumors, they debulked them, and then a couple years later, they came back. The tumor has some inflammation in it, but it's not really so uniformly fascicular like you see in an IMT. It does have some short fascicles, but it also has areas with more haphazard growth. So both of these tumors I just showed you have gene fusions in PDGFRB, which in the literature has been described in IMTs. But if you actually go and dig into the literature, you don't find any pictures. It's just sort of like in series, and you don't actually know what those tumors look like for the most part. So, but that notion that PDGFRB fusions are found in some IMTs has really taken hold. It's commonly written about in textbooks and that kind of thing. But if you actually dig in the literature, there are no pictures of those tumors. And I wonder if those tumors look like this tumor or these two I showed you. So so I went back and we had these two cases back to back. I did some very thorough searches of the archives, and we ended up with 25 of these tumors that all basically look the same. I'm going to show you another one. This is the oldest case in the series. This patient was another 30-something-year-old female who presented with a solitary tumor, but a couple years later it recurred as multiple abdominal masses, and then they just kept recurring, and she ended up dying of her abdominal disease, even though this tumor just looked so bland you would never think it should behave so aggressively. Again, it's multilobulated. This is up against the diaphragm. It's in the abdominal cavity, and one feature I didn't point out yet, but I should, is these tumors have quite prominent blood vessels in the stroma that are reminiscent of the vessels in myxoid liposarcoma or angiofibroma of soft tissue. Those were commonly suggested diagnoses from referring pathologists in these cases because these tumors are myxoid and have these branching blood vessels. But of course, the cytomorphology is not right. The cytomorphology is myofibroblastic. This tumor has a prominent neutrophilic infiltrate, but the inflammatory infiltrates were sort of inconsistent in the series as far as the actual inflammatory population. Again, this tumor lacks nucleotypia, and this tumor has a gene fusion in PDGFRA. And here's a PDGFRA immunohistochemical stain that shows very nice expression in those myofibroblastic tumor cells. So this is another example of a myxoid inflammatory myofibroblastic sarcoma. That's what we call these, sort of to try to parallel the epithelioid inflammatory myofibroblastic sarcomas. You know, the idea being that these are probably related to IMT, but they're more aggressive. And I'm just going to show you, because I know we're running low on time, I don't want to go over, but I'll show you one more case. This was in a young male. This is kind of an old case, so the slide's a bit faded, but again, it's the same thing, multilobulated, growing through the omentum. He again had multiple abdominal masses. This again has the branching stromal blood vessels and very myofibroblastic cytomorphology. So this tumor, interestingly, doesn't have a gene fusion. This tumor has a KRAS mutation. And so I'm going to end by just showing this diagram. So this is a tumor type. We think this is a distinctive tumor type, probably related to IMT, but these are much more aggressive than IMTs. They kill patients. They can even metastasize distantly. We had a couple that went to the lung. They recur like crazy when they occur in the abdomen. About 70% of these were abdominal primaries. The other 30% occurred in a wide range of sites, including somatic soft tissue sites. The only ones that behaved badly were ones that were abdominal primaries. So it seems like that's probably associated with a worse outcome, although we don't have a lot of outcome data on these to know that for sure. But it was interesting. So these mostly have PDGFRB fusions. We have the one with the PDGFRA fusion, a couple of KRAS mutations that look just the same. And we had two tumors that looked just the same. I didn't have time to show them, but they had PML-JAK1 fusions. And these fusions are all hitting the same pathways. So I think that these genetic alterations are all leading to the same biologic endpoint, which is this tumor type, myxoid inflammatory myofibroblastic sarcoma. Okay, I took too long on that one. I noticed I'm running out of time, and I don't want to go over. I don't want to take everybody's time here. But if there are any burning questions, I can answer them, or I'm also happy to talk by email about cases.
And the immunohistochemistry in that case could be a good surrogate for the molecular translocation. Yeah,
so it was very lucky. So I have a case that I actually just signed out today that is another one of these that had PDGFRA expression. We didn't
Mm.
actually test the others though, so PDGFRA is not the most specific marker, so it might just be positive in all of them. I don't really know how well that correlates with the underlying fusion. Unfortunately, the only way really to prove the diagnosis at this point is molecular testing. But I would say these have a very distinctive morphology. And I think if they're negative for ALK. They stain like myofibroblastic tumors. They have SMA and desmin, sometimes keratins even. So if you get a myofibroblastic immunophenotype, they're lobular, myxoid, infiltrative. They have the branching vessels. I think it's okay to just make the diagnosis on the H&E basically. But if you really want to confirm it, you basically have to go to molecular testing at this point.
Okay.
Okay. Well, I took up the whole hour. I actually was too ambitious. I pulled a lot more cases, but maybe maybe some other time I can share the rest of them. Thank you very much for inviting me. I appreciate it.
Well, thank you, David. Any further question or remark for David's presentation?
I see somebody says they had a similar case, which they sounded descriptively, and that's exactly how Dr. Fletcher was sending these out over the years, was descriptively. It was only at the very end when we had those two cases back to back that it clicked. We had these two cases back to back, and they just looked so similar. And then we both thought this has to be a thing. And he told me, he's like, I think I've seen these before, but you're never going to find them. But I was very persistent. I looked really hard through his files to find the cases.
And David, could you repeat the diagnosis of the first case? There is something to asking about how do you figure out?
So this tumor type, myxoid inflammatory myofibroblastic sarcoma, the one that I just described. So these are, we think they're distinctive. I think they're different from conventional IMTs. I would say it's analogous to epithelioid inflammatory myofibroblastic sarcoma, where they're myofibroblastic. They have sort of similar fusions. They're probably sort of related biologically, but they're much more aggressive. So I think it's important to specifically diagnose them for clinical management purposes. Also, I didn't mention these respond quite well to tyrosine kinase inhibitor therapy, at least in one of the patients in our series. It's good to get the diagnosis because it opens up some therapeutic options for these patients.
Only one question for the pseudoendocrine sarcoma with metastatic disease. This patient, how was treated this patient with surgery or?
Yeah, they don't seem to respond to chemotherapy very well in pseudoendocrine sarcoma. Some of the pseudoendocrine sarcomas, some of the primary tumors have been quite responsive to radiotherapy. It's not consistent, but maybe like 30% of them respond quite well to radiotherapy. The ones that respond to radiotherapy seem to have complex copy number alterations. So I almost wonder, in a way, if they're more aggressive, they're also more likely to respond. But yeah, the problem is there's not really good treatment. So the patients that we know of that have lung metastases, they just sort of keep progressing. We have, they're not the most aggressive tumor even in the metastatic setting. We haven't seen any patients die of disease. I am aware of an unpublished case of a patient who died of metastatic disease, but I think it took a long time, or there might have been a surgical complication involved. But yeah, unfortunately, there's not really good treatment for these as far as I know.
Thank you. So, if you don't have any further question or remark,
somebody asked. I'll put my email address in the chat.
Yes.
And yeah, anybody, you're always welcome to send me an email anytime. I like to talk about interesting cases, so it's no problem. On the contrary, I actually enjoy it very much. So don't hesitate to reach out.
So thank you very much to all the attendees, and thank you very much to David Papke for this interesting presentation. David will continue to perform these sessions in a monthly basis. We have for the next session invited John Gross.
Yes, I know him quite well. Yeah,
John Gross, and from the February to Laura from Indiana, and from March Rita Layo. That will be. We'll be giving an update in pediatric sarcoma. So this is more or less our schedule until March of the next year. So you are welcome to join us,
Thank you.
as well as all the attendees. And thank you for your time and for the night case. And see
Thank you
you
very much.
in
Thank
future
you.
sessions. Thank you. Bye-bye.